Good morning, everybody. Today I'm going to discuss about the management of patient with local anesthetic hypersensitivity. As you know that you people are dealing with this drug, local anesthetic, in your day-to-day practice. So you should know how to manage if any hypersensitivity reaction occurs. So I will start my talk with the case scenario. So the patient is 62-year-old male patient. He is a known case of diabetes, hypertension, and coronary artery disease, and he is posted for cataract surgery under some eye block, probably the peribulbar block or subtenon block, and immediately the patient became unconscious after putting the block, and patient complaining of, first of all, restless, heaviness in the chest, and palpitation, and then became unconscious. So the blood pressure was at that time was 80 by 40, and heart rate was around 110, and saturation was also dropping. So a senior resident called for help from us, and meanwhile a quick assessment was done to rule out whether did he overdose the local anesthetic or could the drug have gone to intravascular. So these two things were checked, and it was found that neither the local anesthetic was given in an overdose and nor the drug was administered intravascular. So in today's topic, I want to discuss, basically I want to concentrate on these three headlines. That is, how can we detect a hypersensitivity reaction, how can we treat it, and how can we prevent it. So as you know that commonly what are the local anesthetics available to us, and at this point of time I want to recapitulate your pharmacological knowledge that there are two kinds of local anesthetics, esters and amide. Esters are procaine, tetracaine and benzocaine, and fortunately we are not using ester in our day-to-day practice, and the agent responsible for hypersensitivity reaction in these local anesthetics are the metabolite, which is similar to para-aminobenzoic acid and which causes this hypersensitivity reaction. Now come to the amide group. They are lignocaine, bupivacaine, levobupivacaine, ropivacaine and mepivacaine. And commonly we use these amides in our day-to-day practice, and fortunately this hypersensitivity reaction is very rare. Only one or two case reports are there, and also there is no cross sensitivity is present in these amide local anesthetics. Here the amide group of anesthetics, they per se do not cause hypersensitivity reaction. Only the preservatives, methyl paraben or sodium sulfide or sodium metabisulfide, they causes hypersensitivity reaction. Here I also want to discuss a latest hypersensitivity reaction, because most of the lignocaine vials, they have cork, and when you take the local anesthetic, the needle goes through the cork and it forms some substance with the local anesthetic drug, and which is responsible for this action. The next question is how to diagnose this local hypersensitivity reaction. So there are four category of reactions. One is immediate reaction, second is systemic, and third is localized, and fourth is delayed. The immediate reaction are within a seconds or in a minute, and the patient presents with fever, angioedema, rhinitis, conjunctivitis, pruritus, and laryngeal edema. And they are treated by epinephrine, diphenhydramine, and chlorpheniramine. Coming to the systemic manifestation, they are bronchospasm, they are cardiovascular system, central nervous system manifestation. These have already been dealt by Dr. Josna. And the third is, which is the most, it comes in the immediate reaction, it is a laryngeal edema. So you can see that it's an edema around the vocal cord, and actually I want to discuss this complication because it is a life-threatening. The patient presents with a stridor, obstruction of air, and desaturation. Patient loses consciousness due to lack of oxygen. So the treatment of this entity is oxygenate the patient, call for help, maintain airway, epinephrine, histamine, corticosteroid. These are the medical treatment, and if the patient is not relieved by the medical treatment, then you have to go for surgical treatment, that is cricothyrotomy, because somehow you have to save the life. Then third type of reaction is localized, and fourth is delayed. They are present with like urticaria and dermatitis, and these are basically they are non-emergency entities, so they are treated by antihistaminic and steroid, and patient will be referred to the dermatologist. When these local anesthetic causes generalized anaphylaxis, like patient is suddenly conscious, there's loss of hypertension, there's loss of consciousness, there's a hypotension. So the treatment is as per the standard guidelines of the anaphylaxis. That is, call for help, administer epinephrine 0.3 ml 1:1000 intramuscular or intravenous, and increased severity when this patient is not relieved by this treatment, then second dose will be administered within 10 minutes of the initial dose. Along with this, give oxygen, monitor vitals, that is you have to monitor blood pressure. At least these minimal monitoring or basic monitoring will be required in your OT. So it is my humble request to all of you to please use these basic monitoring like blood pressure, heart rate and saturation. You have to monitor within at least in an interval of 5 minutes. And then if clinical symptoms improve, then additional therapy in the form of histamine blockers and corticosteroid blockers. Coming to the third most important question, that is how to prevent this local hypersensitivity. So I would like to request you that before taking the patient, do the thorough investigation of the patient, take proper history and see the investigation. If you found that, and check the medical record, if you found that any history of delayed, any history of hypersensitivity reaction is there, which is registered in patient's medical record, then you should be very conscious and see the eosinophil count. If eosinophil count is raised, then check for wheezing in the chest. And if the case is not emergency, then postpone the case and refer to the specialist. Now the second step is like do some intradermal test, like prick test or an intradermal test. And if it is negative and surgery is any kind of surgery, then go ahead. And if it is positive, that you can see that there is a wheal of more than 1 centimeter and flare of more than 2 centimeters, then the intradermal test is supposed to be positive. Now again, there are two scenarios. Whether the case is you are operating an emergency case or you are operating an elective case. So if it is non-emergency case, then postpone the surgery and refer the patient. If it is emergency case, then you have two options. See, my whole talk is concentrating on these two things, that choose other local anesthetics. And the most safe, as I have already discussed, that amide group of local anesthetics are more safe. There is no cross sensitivity. So the levobupropion and preservative-free amides you should choose. Always see the vial whether it is written that the local anesthetic is preservative-free or not. The second is ropivacaine. It is a new drug and it is less cardiotoxic. It is safe in pregnancy. So any pregnant female operated for eye surgery under block, use ropivacaine because it is less arrhythmogenic. The second option, you can change the technique. That is, In spite of giving local block, you can plan a patient under topical anesthesia or general anesthesia. Or you can use histamine blocker local anesthetic, that is diphenhydramine hydrochloride. Here I want to tell few lines about diphenhydramine. It is a histamine blocker and used as a local anesthetic. It comes in a 1% solution with 1:1 lakh epinephrine, and it provides anesthesia for up to 30 minutes. In continuation with the prevention, if you have any problem, always before starting the case, you should have some skilled person stand by or present nearby for any emergency help. And always keep emergency drugs prepared like histamine, antihistaminics, that is chlorpheniramine and diphenhydramine. Always load atropine 0.6 milligram, that is 1 ampule contains. Always load adrenaline 0.3 milligram, and steroids should be on your table, at least 2 vials of the hydrocortisone, and keep crash cart ready for emergency intubation and CPR. Now my take home message is always take a relevant history examination and check medical record, and be sure what are the type of anesthetic, local anesthetic you are using, whether you are using optimal dose, and what is the concentration. You can see here that lignocaine hydrochloride 1% is available in India. It is preservative free, so it is the safest. Select preservative free as I have already told you. Use basic monitoring, that electrocardiogram, non-invasive blood pressure, saturation, and tidal carbon dioxide monitoring. And pre-treatment with benzodiazepine. Here I want to emphasize that the benzodiazepine decreases the threshold of the seizures, but on the other hand, it can mask the symptoms of the hypersensitivity. And do the sensitivity test before taking the patient, and keep emergency cart and drugs ready standby. Thank you.